I'll now invite the next speaker, Dr. Abhishek Das. We started late, so please stick to the time.
Good morning, everyone. So today I'll be presenting on outcomes and adverse events following intraarterial chemotherapy for retinoblastoma. It's a single center study. So in the context, IAC is now a first line as well as a rescue treatment for retinoblastoma, and it is a very effective in unilateral group B, C, D, and E. And also bilateral sequential IAC is also reported. Commonly used drugs are melphalan, topotecan, and carboplatin, we all know, but very few reports on IAC and its side effects from developing country like India is reported. So it was a retrospective study. We included 17 eyes of 17 patients. Comprehensive data was collected. All the patients underwent examination under anesthesia. Imaging was done with RETcam and MRI brain with orbit. Intraarterial drugs, we used melphalan, topotecan, and carboplatin according to the body weight. So if you see the results, most of our patients were very far off distance. That means these patients came with a very advanced stage of retinoblastoma. Then we had more of unilateral. We had 11 cases with the unilateral retinoblastoma, then bilateral, and we divided into primary and secondary. So primary IAC only had primary drugs without any systemic chemo or intravitreal chemo, and secondaries were intraarterial along with intravenous or intravitreal. So if you see, most of the patients, 53% came with leukocoria followed by red eye or strabismus or only strabismus. And from the results, most of the patients were group E. So that means that most of the patients came with the advanced stage and they are very far off distance. They can't come in the tertiary center. So if you see comparing primary IC, which had 9 eyes, and secondary IC, 8 eyes, so almost median number of cycles were 1 and 2, and we used melphalan only drugs in 2 eyes, but we usually now use melphalan with topotecan in both the groups, so 6 and 6. And in one patient, we used triple drug therapy with carboplatin, was a very advanced stage. Coming to the adverse effects, so no intervention is without risk and complications. So we found vitreous hemorrhage in 3 patients, regmenogenesis detachment, choroidal ischemia, extensive RP degeneration, of course because of the melphalan, subretinal blood, forehead pigmentation, third nerve palsy with ptosis, and exotropia. So if you see the images, yes, the first image shows the third nerve palsy with complete ptosis, the B shows exotropia, third shows forehead pigmentation, which resolved over a period of time, and the D shows extensive RP degeneration followed 2 cycles of intraarterial chemotherapy. So this was one of our patients with extensive group D retinoblastoma followed by 1 IAC, everything resolved, and we did not do any further treatment for this patient. And also Kaplan-Meier curve shows, IAC shows this globe salvage rate is 93% till 5 years of age. So results, primary IAC 9 versus IAC with systemic chemo where in 8 eyes, mean age at presentation was 21 months, and mean interval between first symptom and presentation was 6.5 months, and each eye received 1.5 IC sessions. 6 patients had familial retinoblastoma, 11 had sporadic, and globe salvage was achieved in 88%. And mean follow-up of these patients were about 28.6 months. So coming to discussion, it's a small cohort study, but IAC is very effective in unilateral RB without the need of any adjuvant therapy such as in primary. If you see the cost, that is a big problem. So in IAC, one cycle approximately cost around 500 to 1,300 US dollars, whereas intravenous it all is hardly 180 US dollars. But with efforts, we tried the government to come into the limelight, and now we have IAC covered under certain schemes. And we found no statistical difference between treatment modality between primary versus secondary IAC. Private insurance, we have no coverage, that is another problem, but yes, state governments are covering systemic as well as IAC recently. So Indian context, most of the unilateral group E undergo enucleation, but we salvaged all our group E retinoblastomas and they are doing very well. We have encountered various adverse effects related to IAC and we have overcome it. But the important thing is case selection is very important. Too much over treating these patients can lead to more adverse effects. So of course, intravenous also plays an important role with active vitreous seeds along with the tumor. And more studies are anticipated, especially from developing nations like India, on the outcomes and overcoming the challenges. These are my references. Thank you.
Thank you very much. It seems the incidence is very high in the place where you're working.
Yes, because the radiologists also, they are very new to this and they don't use intraretinal in any other diseases. So yeah.
So, just a quick question. What was the follow-up of only the Group E eyes? Would you be
So
able to?
we are now having Group E more than 3 years.
Okay, because the only issue I have with IAC in Group E is it does not address the potential for systemic metastasis, because a third of the Group E eyes which were enucleated would have histopathological risk factors which are an indicator for systemic mets if they don't get adjuvant chemotherapy. So, but those risk factors may be mitigated if they've received primary chemo and then come for secondary IAC. So then the comparison and calling a IAC as the hero alone, in that case may not be right.
Yeah, we are also doing serial MRI scans also to look for this.
All right.